All right, I'm going to get started. I'm sure more people will join. So welcome everyone. I'm Dr. Livia Shriki. I started this training company to kind of help people navigate complex issues in treatment. And I'm really excited to have Dr. Colleen Sloan here today talking about DBT with LGBTQ plus youth and their families. So just to note, this is a fundraiser webinar. We're donating all proceeds to the Trevor Fund. We have raised about $500. We'd love to raise more. So I'm going to drop the link to donate in the chat shortly. And I really hope, anything you give, even if it's $1, is helpful. Okay, so because of all the really horrible and scary things going on in the world, I really wanted to create a community where we could come together and support each other and our patients. So this is our first fundraiser webinar of the year, and there'll be more to come. The theme is going to be focused on supporting families. We're going to be having Dr. David Jobs talk about CAMS for teens down the road. Lucine Wisniewski talk about helping parents and loved ones of those with eating disorders from a DBT perspective. And myself and my colleague, Dr. Megan Creedon, are going to be talking at some point about parent guidance in DBT, and hopefully we'll have more on the docket. So today we have Dr. Colleen Sloan. I'm sure many of you have heard of her and already know her. So she's involved both locally in the Boston area and nationally in education and training and consultation with LGBTQ plus individuals and their families. In particular, her expertise is in transgender and gender diverse health. She is a DBT therapist, has expertise in trauma treatment as well, and she focuses her research on LGBTQ plus health disparities and modification of evidence-based psychotherapies, particular DBT and trauma-focused treatments when working with LGBTQ plus clients. We're delighted to have her here today. Before we jump in, please remember that you have to attend the entire webinar in order to get CE credits. We will be sending out links to the evaluation and attestation forms after the talk. If you don't get your certificate right away, please don't fret. You will receive it, I promise. If there are any issues, feel free to reach out. So throughout the talk, Colleen, I'm going to monitor the chat. And feel free to throw your questions into the chat. And with that, I will turn it over to you, Colleen.
Thanks so much for the introduction. And hello, everyone. It's really an honor to be here, and I'm so delighted that you all chose to take time out of your, I'm sure, busy schedules for the presentation today. And big thanks to Livia for opting to do a fundraising platform. I think that, every little bit helps, and it can really go a long way at a critical time. And I think I see some familiar names in the room, so it's good to see folks again. I'm going to go ahead and share my screen, and let's get started. All right. Are folks seeing my first slide? Thumbs up?
Yep.
Awesome. Yes. Thanks so much. Great. So again, I'm Colleen Sloan. I use she, her pronouns. I am a licensed clinical psychologist based in Boston and a clinical associate professor at Boston University School of Medicine. In terms of disclosures, I do receive payments for consultations and trainings, and I will just name that I do work within the federal government. So the views expressed in this presentation are those of my own and do not necessarily reflect the position or policy of the Department of Veterans Affairs or the United States government. This is the outline for the presentation today. You can see that it is packed full. I was just saying prior to getting started, I probably have too much content, which is a bad habit of mine, but I'd rather you have the content than not have it. But at any rate, we'll start with some foundational knowledge, including some terminology and discussions on intersectionality, and then just provide a brief rationale for why DBT with LGBTQ plus youth, an overview of health disparities and invalidation at the systems level, talk a bit about theory and case formulation, and then jump into considerations for therapists, pretreatment assessment considerations, individual psychotherapy considerations, and then importantly, our skills training mode with some tailored applications. And then perhaps most relevant to our talk today, supporting families and caregivers, and then some ideas for team consultation, and leave you with some resources and support for therapists. Here are the learning objectives. I won't go through them as you already have access to those as signing up for this. But I do just want to introduce a positionality statement and acknowledge aspects of my own identity. And I think that this is it's super important when we're doing clinical work to appreciate that we all have different aspects of our identities, and those may align or not align with those of the clients we work with. And it's important to recognize, positions of power and privilege, as well as those that may be more marginalized. So I encourage you to, be thinking about ways that you might incorporate positionality within therapy sessions, within group sessions. And for those of you who publish, even including it within papers that you might write. Those are becoming increasingly common, and I'm really pleased to see that within the literature. So just to start off with some terminology and kind of why it's important, I think it goes without saying that being able to communicate effectively with clients is of utmost importance. Certainly, terminology with young people is ever evolving. I find myself when I go and visit my nieces and nephews at my sister's place, that I have no idea what they're talking about. And so I'm myself am feeling kind of increasingly old. But this is particularly important for LGBTQ plus communities. So language has always been evolving, it's ever changing. And so it's important for us to know what terms mean and how people are using them to describe their experiences. And so we, puts us in a better position to be able to validate and understand. For those of you who are unfamiliar, this is the Gender Unicorn. This can be an excellent psychoeducational tool that talks about various components of identity, kind of where they lie within individual people. This formerly was called the genderbread person, but now has turned to Gender Unicorn, so it's a bit more expansive. There's also a website here if you'd like to look at that. But if you're working with queer youth who are, questioning their identities or may benefit from education around different components of identities, this is certainly a useful tool. Very, very useful for caregivers and parents and other folks who may be important in queer youth lives, who may have kind of less access or historical knowledge regarding different components of identities. Here's some identity-related terminology. So to start, sex assigned at birth. So when we are born, we are assigned a sex by a medical professional based on physical characteristics of our body. We also have gender identity, which is our sense of self as man, woman, neither, both, some other gender. And then our gender expression, which is how we kind of communicate our gender in outward ways or visible ways. That can include things like clothing, hairstyle, mannerisms, voice, things like that. And of course, these the kind of all are kind of culturally bound as well. We have sexual identities, which includes our orientation, oftentimes is a label that we give ourselves. Some people don't actually identify at all with a sexual orientation. And then we have our attraction and our desire, and then our behavior, all different components. And then, of course, our culture, our cultural identity, kind of various components of that. And then intersectionality, which I'll introduce on the next slide. So intersectionality is a concept that was coined originally by Kimberly Crenshaw back in the late 80s, who was a Black feminist scholar. And it was a framework that was used to understand how one's identities result in unique combinations of oppression and privilege. This was in direct response to male dominance in white feminism. And the purpose of this is to really understand kind of the unique constellation of characteristics of an individual and how identity factors really cannot be understood in isolation. And this oftentimes kind of explains the tension between, community of colors and white communities and advocacy efforts. So as an example, we cannot understand a Black transgender's woman's experiences as, this is a transgender person only, or this is a Black person only, or this is a woman only. This is a Black transgender woman, and that in and of itself actually is a unique experience. And we can't take any of those components of identity and understand them in isolation. To further kind of explain this for those of you who are not familiar, this is called the power wheel. And so will has various components of identities on the outside, and on the and in the center are components of those that have more power. And as you move further out of the circle, power lessens. And you'll notice that those identities on the outside are more marginalized in nature. So this can also be kind of a helpful tool to appreciate, positions of power and privilege and marginalization. Here's some additional terminology, particularly as it relates to the trans and gender diverse community. So important to note that not all people who, we might consider transgender identify with the term transgender. Sometimes you might see trans star as an umbrella term. You might see trans feminine or trans masculine, transgender, and sometimes people will say gender diverse. That's one that I typically use. So, and I will actually use the acronym TGD throughout today's presentation. You might see gender nonconforming, gender expansive. And then for folks who don't identify within a gender binary, you might hear terms like non-binary or genderqueer, gender fluid. And then for those of you who might not be familiar, cisgender is for folks whose sex assigned at birth aligns with their gender identity, cis meaning on the same side as. And just important to remind ourselves about terms to avoid. So terms like transsexual are outdated. Transvestic fetishism, things like that can cause a lot of confusion. It's just also important to note to mirror the language that our clients are using. There are definitely generational differences. I know this kind of conversation is about youth. So, for example, when you're working with young people, you may hear terms like queer. And if you were working with someone who was an older adult, that term might actually feel very offensive and triggering. Given historical context. So just again, it's good to kind of do your homework and learn things, and then also listen to what your clients are telling you and reflect that language back. And I have a link here that's through UC Davis. It has a pretty exhaustive list of terminology that may be helpful to you. Things that we want to avoid are things like saying birth sex or natal sex, or things like they were born a girl, born female. And remember that these things are assigned. So we want to say assigned sex or sex assigned at birth, or you may see the acronyms AFAB, AMAB, which means assigned female at birth, assigned male at birth. We also want to avoid directionality, so female to male, male to female. And so, these kinds of terms used to be kind of what was normative. And as we're, understanding more and being more affirming and validating of identities and experiences, we have new suggested language, and this comes from the American Psychological Association. All right, so moving into rationale. So why DBT for LGBTQ plus people? And also importantly, why do we need to tailor? So I imagine that this is not new for the vast majority of you on the call, but the overarching goal of DBT is to create a life that's worth living. As a comprehensive outpatient treatment with 4 different modes: individual therapy, skills training group, telephone consultation, otherwise known as phone coaching, and team consultation for therapists. It is the gold standard treatment for borderline personality disorder, suicidality, and emotion dysregulation. It has a hierarchical treatment target structure so that we can keep people alive, engaged in therapy, and actively working on changing their lives. It has also been shown to be effective to address other co-occurring diagnoses, including things like PTSD, disordered eating, substance use, and it can be integrated with other evidence-based psychotherapies for quality of life interfering problems. So why DBT for LGBTQ plus people? Well, because LGBTQ plus people experience chronic and pervasive invalidation of their identities and lived experiences. And as we'll talk about in a moment, invalidation is one of the kind of core concepts within DBT, and understanding why we might see patterns of emotion and behavioral dysregulation. We also see health inequities, including increased risk for suicide and other mental health problems, including PTSD, depression, substance use, all of which DBT has been found to be helpful in treating. And so, these kind of difficulties reflect general underlying emotional behavioral regulation difficulties. So it's really a perfect fit. And at the same time, there are some limitations. So while DBT skills can function to address problems, transdiagnostically, it's important to note that they weren't really developed for LGBTQ people in mind. And in fact, if you look at the original DBT manual that was published back in 1993, this book exclusively uses she, her pronouns throughout. Which is inherently non-inclusive. The initial RCTs primarily were comprised of samples of white heterosexual, presumably cisgender, although that was not actually even assessed, which in and of itself is problematic, women. Systematic reviews show that of RCTs show that DBT showed about only 11% of the participants reported on sexual orientation and less than 6% reported on gender identity. There is no mention of LGBTQ plus experiences in the skills training manual, even in the second edition. And while research has suggested that DBT is equitably effective for minoritized individuals, it's also somewhat premature to make these determinations. And it's been suggested that modifications are needed when conducting DBT, particularly with trans and gender diverse youth. So I do just want to clarify that this is not meant to criticize dialectical behavior therapy. It's just meant to, encourage us to be continuing to evaluate the evidence-based tools that we have access to, remind ourselves, or do a little bit more deeper digging into on what populations or communities were these treatments tested or assessments normed and things like that. And if those are not fully representative, that should always make us question, and we should always be considering what adjustments or modifications need to be made. So moving into health disparities and invalidation, and just a kind of spoiler alert, this is not great news. So I encourage you to take care of yourselves if you're noticing yourself having a reaction to some of these disparities and instances of invalidation. All right. I've got my references on the side here, but we see pretty significant disparities with respect to suicidal behavior and non-suicidal self-injury. So from various sources during, these are like, past year results. Most of these data are going to be coming from 22 and 23. So we see in the LGBTQ plus youth community that 12 to 20% had suicide attempts during the past year, as compared to 6% for their cisgender heterosexual counterparts. 39 to 41% had serious consideration of suicide attempts. This number goes up to 46% for trans and non-binary youth, and that's as compared to only 13% for cisgender heterosexual communities. LGBTQ youth are also 5 times more likely to be injured during a suicide attempt as compared to cis counterparts. A whopping 63% report engagement in non-suicidal self-injurious behavior, and with higher rates reported for trans and gender diverse communities, which range from 68 to 72%. Also higher for communities, people of color who are also LGBTQ plus, with the highest rates for Native Indigenous folks at 67%. And also for those who did have non-suicidal self-injury, about a quarter had suicide attempts and 59% had seriously considered. So pretty striking rates, very concerning. This is not new, but it certainly is. These trends are worsening over time. Moving on with other kind of areas of disparities, we have 37% reporting high trauma symptoms, which increase the risk for suicide attempts. LGBTQ plus youth are twice as likely to experience adverse childhood events, and nearly half of TGD, or trans and gender diverse youth, are reporting more than 4 adverse childhood events, versus only 15.4% for their cishet peers or counterparts. LGBTQ plus youth are also 2.5 times more likely to develop PTSD when compared to their cishet peers. 66% are reporting recent symptoms of anxiety. Over half are reporting recent symptoms of depression. We see high prevalence of disordered eating, and it's higher than that in the general adolescent population. And this is particularly true for trans and gender diverse youth. And it's been noted that the disordered eating symptoms are primarily related to gender dysphoria, body dissatisfaction, and minority stress, which I will also talk about in a moment. And lastly, we see higher prevalence of substance use rates in these communities as well. In terms of negative experiences, nearly half of LGBTQ plus youth in these studies have experienced bullying, and unfortunately, bullying actually doubles the rate of suicide attempts. So that gives us kind of some insights into relevant factors. About a quarter are reporting physical harm or threat because of their identity, and with higher numbers, 28% for TGD youth. Over half report discrimination, 65% for trans and gender diverse youth. 13% report threat of conversion therapy. You'll notice that I put conversion therapy in quotations because it is not an actual therapy. It is not meant to be used. It is not evidence-based, and it has been shown to cause direct harm to people who are forced to use it. 84% of LGBTQ plus youth wanted mental health care, but only half of those were able to access it. And for trans and gender diverse youth, only 13% are on gender affirming hormone therapy, 2% on puberty blockers, and well over half are concerned about losing access. And just note again, these data are prior to 2024. Certainly a lot has happened in the past year and a half. So if I had to guess, I would assume that these numbers are worse, but these are the most recent data that I was able to find. All right, so let's talk about theory. So why do we see these disparities? I'm hoping that this looks familiar to all of you. So this is the biosocial model of emotion dysregulation, the kind of backbone of DBT. And for those who might be less familiar, this starts with, biological vulnerability within an individual person. So sometimes we refer to this as emotion of vulnerability that transacts with an invalidating environment, meaning that each of these kinds of factors is mutually influencing one another, therefore exacerbating one another over time. So the more emotionally vulnerable we are, we experience heightened emotional arousal. We then engage in ineffective or inaccurate emotional expressions, which then elicits an invalidating response. And then the cycle kind of continues. So that is a very quick and dirty of the biosocial model. But now I want to introduce you minority stress framework, which is what has been introduced to help explain health disparities in LGBTQ plus communities kind of across the lifespan. So I'll start on the left-hand side here, distal stigma-related stressors. So distal, using some DBT language, these are things that happen outside the skin. So things in the environment, whether that be objective prejudice, discrimination, violence, all things that disproportionately impact LGBTQ plus people. These, of course, on their own can actually lead to negative health outcomes, but also lead to those outcomes indirectly through intra processes. Some of you may have seen other frameworks that describe these as proximal stress factors, but these are things that are going on internally or within the environment. So things like coping and emotion regulation. I might start to ruminate a bit more. I might have disruptions in my social and interpersonal behavior. And then importantly, on the cognitive side, I might develop, thoughts of hopelessness. I may start to internalize that stigma and start thinking, maybe something really is wrong with me because I'm this way. Maybe I should consider not being like this or trying to be straight or, trying not to be trans. And so those cognitive kind of processes can also lead to things like, problematic alcohol expectancies, et cetera. And these things naturally lead to psychopathology. So in thinking about ways that we can try to integrate what we know about emotion dysregulation and what we know about minority stress, I'm going to propose this kind of integrated model. um, that combines both. So on the left-hand side, we have, a queer identity and/or expression and lived experience that in and of itself is not problematic, but existing within a larger environment that is non-affirming and invalidating inevitably leads to heightened emotional arousal. And just keep in mind, this is irrespective of biological vulnerability. Certainly, one can assume that LGBTQ plus people could, be one of those folks that's born with higher emotional temperament. But without that temperament, we're suggesting here that it can still lead to problematic outcomes because of the chronic and pervasive invalidation that exists within the larger environment. And I'll talk about this in a moment, but it's important to just note that this invalidation is systemic. So it can happen in the home on a daily basis. It can happen in schools, communities. It's in the media. It's in um, uh, uh, law and policy and politics. And certainly over the last year and a half or so, it has really been pervasive and apparent and somewhat never ending. But nevertheless, when folks experience heightened emotional arousal, they might engage in ineffective efforts to cope, particularly if they are not connected to communities where they otherwise have access to adaptive and more healthy kind of coping strategies. These then elicit invalidating responses from the environment. So you may have seen examples of this where people who are marginalized or minoritized are engaging in very reasonable efforts to cope, but nevertheless are ineffective. And then that is kind of used as a way to pathologize them, those kinds of things. And so the cycle kind of repeats. So this is a way of, thinking about how to integrate both models in a way that makes sense and also lends itself really well to DBT as a treatment. All right, so let's take a closer look at systemic invalidation. So this is, let's see, this is back from March 2025. So this came out in the New York Times. And essentially these words that are fairly specific to marginalized communities were being kind of banned or erased. As somebody who definitely has experience within a federal agency, I can attest to that. So things like, gender doesn't is not a word that we can use anymore. That's all ideology. Proclaiming that there are only two sexes, things like that. So these words were effectively banned. It did affect some federal entities more than others. So the CDC, for example, was hit pretty hard, and certainly acronyms like DEI, DEIA, et cetera, were also banned. Can't say things like pregnant people, that kind of thing. And here are some other examples of policies that have specifically impacted LGBTQ plus people. And we'll talk about the executive orders in just a moment. In terms of anti-LGBTQ plus legislation, the ACLU, or the American Civil Liberties, is tracking these kinds of bills throughout the US. So in 2025, they were tracking 616. And then important to note that here on the side, that roughly 1,000 bills were introduced in 2025 as compared to 100 in 2020. So we're seeing 10 times more in just a number of years. And then we see already in 2026 that 345 are being tracked by this organization. Why does this matter? Well, because health correlates actually with geographical region. In areas that are more conservative and or rural, we do see elevated rates of discrimination and violence towards LGBTQ plus people. We see poorer health, and we also see inadequate access to healthcare and insurance. And then on, how is this impacting folks? 90% of LGBTQ young people report that recent politics negatively impacts their well-being, many of which are saying that it severely impacts. For those who are living in accepting communities, suicide attempts are less than half of those in accepting communities. And 39% of LGBTQ young people and or their families have considered moving to a different state because of LGBTQ related politics and laws. And this number is higher for trans or non-binary folks. Here is just a quick list of the anti-LGBTQ executive orders. And so since January 2025, there have been, let's see, six that are specifically targeting LGBTQ plus people. I have the first two starred because these are specific to LGBTQ plus youth. And of course, you will not see language in any of these titles that says anti-LGBTQ. It's framed as something different or something that's actually positive or protection oriented, which in and of itself is kind of more intense invalidation. Perhaps you're also familiar with grant funding and cuts and cancellations for research that, you know, investigates things like sexual orientation, gender identity, LGBTQ plus health, or anything, quote, DEI. I won't read this out to you, but this is an actual quote that comes from the cancellation notices for folks who are doing work in this area. Um, kind of zooming in a bit more, we also see invalidation in environments of care. So I'm talking about, healthcare facilities, et cetera. What does this look like? Well, it can look like lack of training and competency, whether that be at the administrative staff level or even at the care providers level. Important to note that LGBTQ plus health historically has not been included in curricula. I think this is particularly true in medical settings. Can't tell you how many times I have been in kind of small in-service and I'll ask people to raise their hands if they had LGBTQ health as part of their training. And I see maybe one or two hands pop up. So it's an ongoing problem, even though it's been recognized as a problem. And then, of course, we have provider biases, whether these be, conscious or unconscious, implicit or explicit. But we do see that folks, either endorse or don't think, but still have biases, and that this actually affects the care that they're offering to LGBTQ plus patients. There are also conscience clauses or agreements. So this is when healthcare providers can file these agreements in their personnel records that kind of keeps them from having to provide things like gender affirming care, as an example, because of deeply held religious beliefs. And then, of course, lack of tailored services or just inadequate resources on the whole. And then this can spread to school and community settings. So mentioned earlier, identity-related victimization is a thing. So we can see things like bullying, harassment, slurs, misgendering, or dead naming. So for those of you who are not familiar, dead naming refers to when we call a trans or gender diverse person by the name that they were given at birth and not their chosen or affirmed name. So repeatedly using that over and over. Important to also note that many medical record systems still do not have a preferred name field. And so there are kind of administrative barriers to affirming someone within a healthcare space, but nevertheless, that means that the system itself is inherently biased, and that means that a person walking in either is at risk of being outed, experiencing stress, and otherwise, another barrier to getting healthcare that they need. And these kinds of experiences are associated with increased depression, anxiety, suicidality, and also school avoidance, which makes sense and is a problem. So we've got kind of overt experience, and then we also just have erasure. So acting as if these identities don't exist at all. So an example would be "Don't Say Gay" bills, which again we're framed in a very different way, but ultimately we're intended to erase diverse sexual orientation discussions within schools. And then similarly to healthcare settings, we can have educator or community leader biases, and then lack of safe and affirming community spaces, which is particularly important for our youth. Okay, so essentially just kind of talked about this. Experiences of microaggressions within families, schools, and local communities within treatment spaces, and then inadequately tailored treatments can be problematic as well, which is why we have webinars like these. Also important to note that there's intra-community stress. So it's not just like, the in-group, the out-group type of thing, but there's also within queer communities, things like isms exist. So things like racism, sexism, sexism, and other prejudices. So, especially for folks who are multiply marginalized, this is added stress, and important to note that they may have extra challenges in finding supportive communities because of these isms and because of multiply minoritized identities. There may be also IPV specific to LGBTQ communities, which can include things like identity abuse or outing or threat of outing, those kinds of things. So just bring this up to be aware of some of these kind of differences that may be more nuanced. So this is kind of an overall summary of LGBTQ plus invalidation. So things from sports bans to misgendering, to calling a partner a friend, those kinds of things. Just the binary gender system at large, bathroom bills, lack of legal protections, and then importantly, if you'll see down at the bottom center are these pathological narratives about LGBTQ plus people. So saying things like LGBTQ plus people shouldn't be around children. This is why we're banning drag shows, or referring to TGD youth transition as child abuse. And you'll see back in that executive order that they refer to this as mutilation. All right. So let's move on to things that therapists should consider. You know, we're all people, and with the best intentions, we still have things that we might not be aware of, or things that we can continue learning. So one thing to consider is working on continuing to increase cultural responsiveness. And I'm deliberate with the language cultural responsiveness in lieu of cultural competency, because competency suggests that there's something to learn, and once you learn it, then you know, and you don't need to learn anything else. Whereas responsiveness or humility really refers to lifelong learning. So, as somebody who does talks like these all the time, I don't believe that I would call myself an expert, but somebody who is dedicated to lifelong learning, and to recognize that I will always have, shortcomings and things that I do not know about, identities and lived experiences that I do not hold, of my own. And to be culturally responsive really requires honest self-reflection, and good news, dialectical thinking, which we all know how to do as DBT therapists. This comes from Hayes in a 2008 book. So things that we can ask ourselves: how did I come to this understanding? How do I know this to be true? Are there alternative explanations? All things that actually sound like good DBT. So things to keep in mind when we might be having certain reactions to behaviors that we see within the therapy context, especially if the person who is engaging in those behaviors has different identities or lived experiences than we do. I encourage you to consider Hayes's addressing model. We can use this in group settings. We can use it in supervision, and consultation team meetings, those kinds of things. And it is available for free down at the bottom. Okay. In terms of pre-treatment and assessment considerations, just doing a quick chime check. We want to exercise caution when assessing identity disturbance, especially if it's specific to sexual orientation or gender identity. Changes in this is actually normative, and over time, and is not inherent of a quote identity disturbance. So important to keep that in mind. I would also encourage you to perhaps consider the APA cultural formulation interview, which invites clients to describe presenting problems in their own words. This is also available for free online at the link below. All right. So thinking about what some things that we might consider in an individual therapy context. One is on the diary card: consider tracking targets that are relevant to minority stress. Have open discussions about minority stress, how this might manifest, and be able to name that it is something relevant to track. So we might include things like shame, pride, identity concealment, which may or may not be adaptive, identity affirmation behavior, activities that promote pride, media consumption, and if that's effective or not, and advocacy activities if that's values consistent. When working with trans and non-binary folks or gender diverse folks, it may also be helpful to track gender self-affirming behaviors, or GSABs, because we like our acronyms. Examples can be things like wearing affirming clothing, including undergarments. Sometimes you can get a lot of bang for your buck for undergarments because they can feel really good to wear, but nobody sees them. So folks can wear them out, and maybe feel a bit safer in doing so, and still get, a good dose of affirmation for themselves. Other things include, applying makeup or shaving, connecting with spaces, cosmetological practices, etc. One thing just to note is that it's very important to consider context for practice. So when we're wanting folks to engage in more gender affirming behaviors, ideally they would be doing these things in public. Not all public spaces are safe. I think that this is not surprising that I'm saying this given all the things that I just talked about. So we, as therapists, we really need to be very knowledgeable about the communities that our clients are living in and ensure that objective safety is, good enough to actually increase the likelihood that these are successful. And if not, don't assign them or create those spaces within your environments of care within your clinics. Speaking of, in-session exposures can be awesome because that is definitely a safe space. You are the one who's working and creating this. So this creates opportunities for that corrective learning, for therapist acceptance. This can be a great antidote to shame. It allows for colleagues to participate. So you can invite your colleagues to come in and ensure safety and skills coaching is readily available. So again, just want to reiterate for homework assignment consideration, it does need to be centered on the client's experiences. They should be collaborative, transparent, and objectively evaluative of potential risk. All right, so moving on to skills training applications. Just a brief overview of the different modes. We have mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. What are we working with people to do? We want to build skills so that we can help our LGBTQ plus youth cope as effectively as possible with ongoing minority stress and increase connection with validating and affirming environments. Some considerations to keep in mind, a positionality acknowledgement, similar to the one that I did at the outset of this talk. This could be especially helpful when group leaders are not LGBTQ plus identifying. So just, naming, we don't share your identities or lived experiences. We honor your inherent wisdom that you have. And so just to name those things and be transparent. And that's also kind of embracing that cultural humility type of approach. Some other considerations are group makeup. So this may or may not be feasible in your care environment, but it likely would be ideal to have LGBTQ plus only groups versus mixed identity groups. On the one hand, we can think about this dialectically, and this is a conversation that I've had with mental health leadership at my agency. Why wouldn't we want everybody to be in the same group? Like, doesn't that resemble real life? And isn't that actually what we're trying to help our queer clients cope with? Like, they're going to be around cisgender and heterosexual people. So why not have group as that space? Totally makes sense. And I can validate and appreciate that side of the dialectic. On the other hand, it sets up a scenario where there may, even if inadvertently or accidental or, well-intentioned, but bad things can still happen. Somebody can be misgendered, somebody could be dead named. And now we have, replicated one of those negative experiences that happens in the environment that's now happened in the care environment, which may decrease the likelihood that a person who needs therapy to return. So that is just one thing to consider. I don't think there's a right or wrong answer, and certainly there are other logistical complications and factors that come into play, but something to keep in mind. Likewise, we may also see creating spaces that are specifically tailored for trans and gender diverse people. In my setting, this is something that we ultimately did. So we do have a DBT skills training group that is for trans and gender diverse people only. And all of the teaching points, discussion points are tailored to TGD, identities and lived experiences, gender minority stress, transitioning, things like that. And then, of course, this is not necessarily specific to the communities we're talking about now, but just important to consider, do we want this to be a standalone group or part of standard DBT? There is some evidence to suggest that standalone skills training could be beneficial, and that actually may be more feasible in a clinical setting. So again, just some important considerations. For those of you who are doing group, here are some things that you can consider in your orientation session. So you might want to consider modifications for group guidelines, the skills training assumptions, and the psychoeducation that's presented as well. So here are some additional options for group guidelines. So in addition to the ones that are published and do a very good job. We might also consider adding participants make every effort to center the experiences of the most marginalized group members. That is a way to be most culturally responsive. And even though we have some, limitations to outside relationships for our LGBTQ plus people and particularly youth, there may be very limited to no opportunities to actually connect with other folks with shared identities and lived experiences outside of the therapeutic setting. So you may consider participants may form skillful friendships with other group members. And then lastly, participants agree to engage in a repair protocol after engagement in behavior that is harmful towards another group member. And again, we're not making any judgments regarding the intention behind this. We're more so validating the impact or outcome that it has on somebody else. And this is an opportunity to have folks be more mindful of their behavior and then also practice repairs when microaggressions occur. So in terms of the orientation session, encourage folks to consider integrating minority stress theory and include the discussion of intra-community stress, and then have an expanded kind of discussion on the larger invalidating environment. And there is this handout over here that originally published by Jeff Cohen several years ago that looks very much like it belongs in a DBT skills training manual that's specific to stress that impacts LGBTQ plus folks. All right. So let's jump into some tailored applications of the skills themselves. This is not comprehensive. I do have lots more that I actually had to cut just for the sake of time. But do just want to hit on the importance of incorporating loving kindness. This is a very useful way of practicing mindfulness to target internalized stigma, and a kind of a teaching point that you can raise either within a group or an individual setting is to talk about societal stigma, about these identities and how they are so pervasive and intense that we may start to internalize those messages. And so using loving kindness meditation towards, oneself, towards another LGBTQ plus person. And then I do think this may be optional. It can be good for practice, but sometimes really hard, especially when people are overtly and objectively harmful toward a person with whom you're angry. So again, it's what we ordinarily would do, but we're just tailoring it slightly to meet the needs of the folks we're working with. I found this online and thought it was just awesome. So this is actually 10 mindfulness practices for Pride Month. You can click on this resource and hop over it there, but these are mindfulness exercises that are tailored to LGBTQ plus communities. So love what we can find sometimes on the internet, especially when it's for good. Okay, let's shift gears and talk a bit about applications of distress tolerance skills. So, certainly considering things for crisis survival, when safety is objectively impacted. So as an example, if somebody's in need of medical care or they, theoretically would be in need of law enforcement, it's important to note that getting medical care or getting help from law enforcement is not a universally positive experience for everyone. So certainly if we have a Black transgender woman who needs medical care for maybe a surgical revision or something else, or because she's just been attacked by someone, she may not actually get the medical attention that she needs because of bias within the healthcare system. Or she may actually be further assaulted by law enforcement if she reaches out to law enforcement. And in fact, there is data to support this. Trans Black women in particular have some of the highest rates of disparities and have pretty significantly negative interactions with law enforcement. For those of you who are interested, you can look at the United States Transgender Survey. The most recent administration was in 2022. It's a pretty comprehensive assessment of trans and gender diverse people's experiences kind of across the board. I didn't include that in here just because it is 18 and older, which is not specific to the population we're talking about today. But we also may need to, think about not just crisis survival, but actually adding case management and problem solving to supplement for some of our folks who may be facing objectively harmful stressors. Certainly, this comes up, and it feels really challenging to work with folks to increase acceptance when the kind of overall environment is looking so bleak. And it's important for therapists to be knowledgeable of what these realities are. I certainly won't sit here and tell you what you need to do as therapists in terms of being aware. I know everybody has their own limits in terms of what they can tolerate, and how they cope most effectively. And if we do not have knowledge about, what is going on that is specifically impacting LGBTQ plus youth, it will be very difficult for us to work on with our clients and their families to increase acceptance. Not because this is, any of this is morally acceptable, but so that we can help our folks reduce suffering and just cope with the natural pain that makes perfect sense given the environment. I just wanted to note DBT SUD skills. LGBTQ adolescents are at substantially greater risk for substance use. I have a couple of references here. So definitely encourage you to pull out the SUD skills as well. And want to encourage you to be thinking and exercise caution with the alternate rebellion skill in particular. So, generally speaking, alternate rebellion can, be something that gets a little bit of attention, kind of, scratches the itch for folks who may be struggling with substance use, and for somebody who may benefit from not having a lot of attention to themselves because it could actually elicit harmful behavior. It's important for our LGBTQ plus youth clients to be cautious when they're using this particular skill. And you see that I have it in bold. I'm going to invite therapists to flex this as much as possible. So, things like wearing a rainbow lanyard or having pins, or having, visual cues in your office, those kinds of things, especially if it's not necessarily something that's welcomed where you are working. Sometimes flexing that can be super important and very effective, and can be just the thing that our clients might need to see and experience. All right. Moving on to interpersonal effectiveness skills. I'll give you some examples here. Here is it looks obviously very similar to what you would see in the skills training manual, but it's specifically tailored to someone who is trying to communicate pronoun use to someone else who is not affirming that. So describing the situation could be, you keep using my incorrect pronouns and my dead name, despite me correcting you and asking you over and over to use my chosen name and pronouns. And I'm feeling so hurt by this, or I'm starting to think you don't believe that this is important to remember, or since this is who I am, I'm feeling really insulted. I'd like for you to stop using my dead name and to start using my chosen name and pronouns when you address me or refer to me when talking to others, even when I'm not present. That's also an important thing to consider. Then lastly, not using my dead name would help strengthen our relationship so much, or this would really make me know that you care about and respect me. So these are, real conversations that our youth are having with people around them, including their parents and caregivers and other family members. Or it could be, caregivers who are communicating this to other people within the family. So sometimes having, this written out and practicing this in a group setting or an individual setting can be particularly useful. Here are some ways to enhance the give. I'll talk about this. I'll kind of reinforce some of these concepts when I get to dialectics in just a moment and walking the middle path. But here are some good examples of validation. One of the things that we can, think about is to the best of our ability, we want to always be working to center the experience of the one who's marginalized. And so in this case, it would be, centering the experience of the LGBTQ plus young person who we're working with. And parents have power, and they also have, very real reasons for having perhaps negative reactions to identities. So as much as we want to work with parents, it is also important to work with our young people to communicate as effectively as possible. This can be, really good practice, and likely will be translatable. So Things that folks might say is, I know it's really hard to switch given how long you've been referring to me by a different name and pronouns. And so doing our good old dialectics, I know it's hard for you to remember this, or I know it's hard. I know that this is a difficult adjustment for you to make. Or I can understand how you might still think of me in the same way you always have. And that's something that comes up often, like, oh, no, I totally respect you, but I've always known you as so and so, or like you've always been like a brother to me, those kinds of things. So, okay, and that I can appreciate that as kind of a vulnerability or why it might be more challenging. And I'm still asking you to do this. Or I can understand how me making changes impacts our relationship. Those are very real things that are impacting parents, caregivers, and other family members. When, particularly for folks who might be undergoing a gender affirmation process or, discovering sexual orientation, things like that, it does have effects on other folks. And that doesn't mean that it can't happen. Okay. One thing that, yep, go ahead. Sorry. Somebody say something. Oh, okay.
I don't think so. You can keep going.
Thank you. Opinion debates. Also put those in quotes, like I did conversion therapy, often are used to invalidate the identities and lived experiences of LGBTQ plus people and other minoritized people for that matter. It is inherently invalidating and harmful to frame an identity or a lived experience as an opinion. So keep that in mind. Those things could come up perhaps like in family sessions, things like that. And we want to make sure that we never validate the invalid and that we are challenging things that are important to challenge. All right, lastly, for the skills portion, applications of emotion regulation skills, there's a good bit of content here. I cannot see the chat, but we'll just invite folks to throw in the chat what emotions do you think are associated with internalized stigma?
Shame is so far.
Okay. Yes. Depression and that.
Depression,
All right,
anxiety.
cool. Yes, right on the money, everybody. Fear and shame, right? And when we think about prompting events for fear, so this is just a reminder that comes directly from the skills handout, having your life, your health, or your well-being threatened, being in the same situation where you've been threatened before, being in situations where you've seen others hurt. All of these are prompting events for fear, meaning that fear is justified, which also means that avoidance makes sense. The thing to keep in mind is how the avoidance is actually functioning for folks when you're working with them, because there is kind of a healthy amount of avoidance, as we just named, and it can become overgeneralized in a way that becomes ineffective, and it's important to be able to kind of tell the difference. So, as an example, effective avoidance would be avoiding specific people or situations in which invalidation or any other kind of harm is likely to occur. Ineffective would be overgeneralized fears that cause impairment. Effective avoidance would be altering one's expression or concealing identity when invalidation is likely, versus ineffective, where altering one's expression or concealing is unlikely. So, I've certainly been in settings where there's been kind of a push, with good intentions, like, oh, somebody needs to be like as out as possible across all contexts. And in some kind of ideal world, yes, that would be true, but it doesn't actually ring true for everyone. And not everybody actually has access to those kinds of spaces. So there are times where it is actually effective to hide. Just like we were saying because the fear makes sense. And when objective risk is high, that's actually what we want to be working with people to do. And then, of course, that has costs to it. So we want to also work with our people to find, ways of coping. I can give an example. So I work with a trans woman client. who, again, sees me in an environment that has been very unkind to trans people. And so she makes a habit of wearing a mask when she comes into the hospital. And when I ask her why she's wearing a mask, and is it for health related reasons, she says no, that she's actually trying to hide because she is trying to avoid people paying attention to her and negative unwanted experiences. And so, at this point, like we have really good rapport, and I've asked her, how often are you experiencing, people knowing about your identity, or are you receiving, harmful kind of attention? And she says, actually, never. Since she's had a number of different medical interventions, she, quote, passes pretty much 100% of the time. So we have been able to name the mask wearing as overgeneralized and as a problematic behavior. And the reason why is because that is teaching her brain that she actually needs the mask in order to be safe from, anti-trans kind of behavior. Not the flu, not the cold, but she's actually, trying to avoid negative behavior from the environment based on her identity, not her physical health. And oftentimes she will cite kind of other examples that she's seen in the news of trans people being harmed in these kinds of settings. And so validate, 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 and then work with her specifically to try to empower herself so that she has a realistic understanding of spaces where she is objectively safe and where invalidation is more unlikely. Because that's actually what her actual experiences are. And that will also help her brain be more objective when it's evaluating risk in other contexts as well. So that is kind of a real life example. So, and of course, there are some dialectics involved. Identity concealment may be values-based, may be adaptive, especially in invalidating environments. And on the flip side, it can also reinforce internalized stigma, can reinforce trauma-related symptoms if those are present, and importantly, block opportunities for corrective learning. So we always have to kind of keep this in mind and be thoughtful about this balance when we're working to intervene. So what about shame? How do we regulate that? One way is by experiencing pride. Pride is the most effective antidote to shame. And it's important to check in with our clients about what pride means to them. It feels and is experienced differently by everybody. So I've got a handout that I created a while back that looks very similar to what you might see in a skills manual because we don't actually have a pride handout in the emotion regulation content. So this is a tool that you can use with folks to, talk about different ways of describing pride, prompting events for feeling it, different interpretations, biological changes, expressions, and actions, and then after effects as well. And importantly, the after effects, generally encourage people to seek out more opportunities like that. Right. People, feel empowered. I remember myself going to my first Pride parade. I don't think I had ever seen that many queer people like ever in a space before. And it made me want to do more of that. And I was just so taken aback at how, everybody was expressing themselves. And it really does, give you a boost. These things are important. It doesn't have to be a parade necessarily, but having spaces where you have access to authentic self-expression without being punished is immensely necessary for the folks that we're working with, and particularly youth. Our youth right now are bombarded with messages about how bad things are, and this can really lead to a sense of helplessness and hopelessness and difficulties really seeing a future for themselves. So the more that we can work to find those spaces, and if they don't exist, create those spaces for them, those can provide corrective experiences and opportunities for more positive emotions. Easier said than done, I know, but not impossible. Speaking of additional emotion regulation skills and ways to boost mood, here are some examples of accumulating positives. I want to, in particular, highlight this first one, learning about LGBTQ plus history. If you if you talk to a youth, an LGBTQ plus young person about hope for the future, you're probably going to get a pretty bleak report. Things don't look great, and how it's very difficult to actually think how is this going to improve, especially for a young person who doesn't have a lot of life experience. one of the things that can be really helpful is talking to an older LGBTQ plus person because they've been around for a long time, and you almost 100% of the time you'll hear like, "This is not my first rodeo. We have seen this before. I remember when we were marching in the streets. We've been through the AIDS crisis. We've been through, insert kind of problematic stuff here. And then we always come out on the other side. That can really work to instill hope. And I encourage folks to, get your young folks connected to history, important people in history, and how things have changed because progress is never linear. It can be really bumpy, but it can still, be towards progress and affirmation. Similarly, we can watch, film shows or other media, attending events. I have drag shows with a star because they're banned in some places. But consider youth events. Consider looking at your local community for youth-related supports for LGBTQ folks. I've mentioned Pride events already. It can also be really great for folks to get connected to social media influencers who are kind of encouraging empowerment in safe ways. Consider creating a Pride playlist, develop or joining a book club that's oriented around, LGBTQ literature or has folks that might have shared identities or lived experiences or interests. Starting a blog or engaging in writing that centers these experiences, and if values consistent, engaging in advocacy. And then more specific in terms of advocacy efforts for folks who really get a boost off of engaging in social justice efforts, that can be really empowering. We don't want to force that if it's not consistent with someone's values, but that can be really helpful for folks for whom it is. It can also be something, if we do have parents or caregivers or other family members who are supportive, this is also a way that we can invite them to get involved. And that can really instill hope for our clients when they see members of their families or communities engaging in these kinds of efforts. Okay. And then our good old cope ahead plan. This is essential for coping with minority stress. Minority stress is not going away. These things exist within the environment, and it is important for us to work with our clients to be able to figure out how they're going to cope with that. And by figuring out how to cope with it is not the same as us saying that this is acceptable. It is acknowledging a reality. It's also possible that even in environments that, generally speaking, are safe, something could happen. I live in a very progressive neighborhood, and every now and again there's like a slip and something happens where you're like, wow, that is not typical. If you're working with someone and they're actually doing kind of an exposure assignment or something else and something like that happens, that can be really derailing, and we want to make sure that we always have cope ahead plans in place. All right, so just a note on allyship. Important to note here, and this is really, really useful for families. Again, well-intentioned families, may or may not want to engage in allyship, but others may, and we just want to remind them what this actually looks like. It's about active support for advocates for rights and needs of marginalized people, flexing or using one's own privilege to amplify marginalized voices, making a commitment to work to dismantle systems of oppression, engaging in active listening and learning. Even with the best of intentions, you still have blind spots, and it's important to be mindful of those and to continue to engage in self-reflection and to hold yourself accountable. So I also have a handout for this in case people are interested. It could be something that you might use, again, with families, parents, caregivers, whomever, or even part of chosen families, if that's in the mix as well. So just something to consider. All right, speaking of families, let's get to some of this content. All right, so what do we do when families are not affirming of our LGBTQ plus young clients who we're working with? Well, the good news is the Walking the Middle Path content from the Adolescence Manual can be easily applied to this. And I don't say easy like it's easy to do, but it actually makes a lot of sense. So why would we consider this It's not uncommon for LGBTQ plus youth to face family level dialectical tensions. Identity, safety, and autonomy can produce polarized positions. So we may actually see that polarization happening within these families. Polarization usually leads to invalidation, which leads to emotion dysregulation. And then we see these kind of conflict cycles. And it's very hard to get out of that. These are not necessarily unique to LGBTQ young people and their families, but they can have kind of a certain nuance about them that's just important to be mindful of. And this provides us with a structured, non-pathologizing way of approaching and resolving these tensions within families we might be working with. So let's think about some dialectical dilemmas that may be present for LGBTQ plus youth. So tension between being authentic and being safe, being totally autonomous and needing guidance, wanting to explore identity very freely, and then having fear about that, particularly on the parent side. Really wanting privacy to be who you are and with yourself while also wanting connection. Looking for stability while also looking for change. And then some quotes here at the bottom. So I know who I am, and parents saying, like, you're too young to know. And that's a question that comes up a lot. Like, how do they know that they are trans? Like, they're only 13. Kids know. Actually, gender identity can even firm up for many folks around like 3 or 4. We see children engaging in behavior that indicates to us that they know who they are. And at the same time, of course, they're still exploring, because all people during adolescence are exploring, and that's actually developmentally appropriate. So those are all kind of things to keep in mind. 3 components for addressing are our validation skills, engaging with dialectical thinking, and then using behavioral principles. So we can just walk through these. So what are the things that we want to validate? Irrespective of, what we think as parents, caregivers, or whoever else, we can validate someone's identity. If someone says, I am whatever, we can validate that. That is your truth. Even if it is temporary, even if it's just in this moment, this is how you're identifying yourself, I can validate that. I can validate the emotions that you're experiencing around, what it feels like to identify yourself in this way, or the fear that you're experiencing in the world that you're existing in. I can validate the developmental context. I can also validate risk exposure. It's important for us to acknowledge that as a truth. And then on the parent side, validating caregiver fears. It's not, goes without saying, it's not uncommon for, parents to look like they're angry or just non-accepting when really they're just immensely afraid of what's going to happen to their kid if they authentically express themselves, or if they undergo a gender affirming intervention, all of those kinds of things. So that makes sense. And it's important to validate that also. And that's not negating the experience, it's just acknowledging both. Speaking of, here's some examples of some dialectical thinking. So some things that we want to work with parents and caregivers, families, etc., is that you can be scared while also being supportive. And we need to work with you to figure out like what that's going to look like. Ways to, manage your fear, and then behaviorally support. Things that we might say to our young people: you can know who you are and still explore. Exploring identity is not pathological, and it doesn't mean that you are unstable. It just means that you are a young person who's still forming that, and that's fine. Also important to note that there are so many factors that are playing a part in identity kind of affirmation. With a hostile environment, it's really hard to figure out like who you are, because it's actually very reinforcing to, be reinforced by the environment. So if the environment's telling me that I need to, be more whatever X, Y, and Z, I might seek that out for a little bit because it actually feels pretty reinforcing to do that. And it's nice to get a break from, the punishment that I ultimately experience. And then over time, I might start to realize, like, I'm not doing this for me anymore. I'm doing it for somebody else. And so there might be a shift. You can want privacy and also want connection. And you can affirm identity and move at a pace that actually feels safe, and doesn't increase the risk of violence or some kind of other harmful behavior. Some behavioral principles we want to keep in mind. We want to ensure positive reinforcement for effortful identity affirming behaviors. So, parents using correct pronouns, or correct names, those kinds of things. Keep in mind, shaping is important too. Oftentimes when we're working with youth, they want like everything all at once right now. And providing them with some psychoeducation about what shaping is and how we want to work towards something, maybe even relating it to their own treatment goals, that we would never assume that the things that they come to treatment for, that they're going to get those in one day. Same thing goes with parents, and working with our young folks to practice their distress tolerance skills while the parents are still learning, is just as important as everything else. So as an example, in these kind of incremental changes, so it could start with things like, okay, I'm going to use your pronouns, I'm using your name, to, I'm the biggest advocate you've ever met, and I'm leading the Pride Parade now. But we can't jump there right at the beginning, and we kind of have to honor where families are at the outset. We also want to make sure that as therapists, we are working to extinguish any invalidation traps. So arguing, polarization, shutting down, avoidance, those kinds of things. And then when we do see conflict patterns, so it's important to have those sessions as well. Conduct chain analysis, understand where they're coming from, where things kind of went south, started to go awry, and how people are thinking and feeling about it can always be a great way of assessing what specific problems there are and how we can solve them. So things that we would just want to be aware of, these are like, the therapist traps that we've seen before. Number one, treating neutrality as safety. So like, oh, I stay out of all of this, and that's the safest thing to do. It's almost akin to like a colorblind perspective. That's not actually useful. It doesn't mean that these things don't exist. They still do exist, and you're just ignoring them, and ignoring it is actually invalidating. So we don't want to do that. We don't want forced outing framed as transparency either. Um, Over pathologizing identity and exploration. So again, these things are normative. We may even say that when we're working with any kind of adolescent, but it's especially important for folks with marginalized identities. We want to not are reinforcing avoidance of identity conversations. We want to work with our young folks to not assume that parental fears mean that they're being rejected. And then on the flip side, we also want to work with families to not assume that youth autonomy is equivalent to hostility. I think I saw a digital hand.
Yeah, it looks like there's a question about working with parents. So this particular example is in a multifamily group where a parent refused to stop using the dead name of the child. And just in general, speaking to working with parents who are very like anti and resisting any kind of shaping would be great.
Yeah. I mean, I don't know if there's a right answer here, because my gut reaction was I might actually not ask that parent to be in the group anymore, um, especially if they were in front of their child and they still need the help. But I might try to find like another way of doing this. Like maybe they can call them like a letter or something. I like, this is off the top of my head. But I would get like, I would keep talking to your teams and try as best as possible to get consultation, because I don't want to make any hard and fast rules. But it would be unacceptable to allow a parent to continue to aggress against their child and like cause them harm in a therapeutic context, period. Now, if they're in a group with other parents, that might be a different story. But my hope would be, and this is actually on another slide, I do think it would be very helpful for parents to be with other parents, especially like who have been at kind of varying points on the journey of their kids' identity journey, because it can be really helpful to hear another parent say something like, hey, I was where you are. I know what you're feeling right now. I used to do the same thing. This is a journey, like you're along for the ride type of thing. Because some of that like peer-to-peer corrective feedback can be very useful without the therapist coming in and kind of shaking the finger. That's not a great answer, but and I think there are a variety of different ways to do this, and you may not have access to those parent groups. But that is one thing to consider. But I do think that there may need to be agreements on like this behavior just cannot happen, and this is just unacceptable, and you won't be doing this in this setting, especially if it's causing harm to somebody else. Okay, so we've got 10 minutes. Here are some additional strategies. So I have a ton of resources on these last couple of slides when we get there. Education is really helpful. So there's good research that shows that um, less knowledge about identities actually is indirectly related to higher levels of prejudice. So it goes without saying that education can be really helpful in lowering those negative attitudes just because you're simply learning more about it and realizing, it's actually more normative than you think. So one thing to do for you as therapists and clinicians to be educating yourselves, and then to be able to kind of communicate that to families you might be working with, assign them for homework that they have to review at least, one website or read one handout or something between now and next session. Having skills groups for parents where they're practicing things like, dialectical thinking or validating things like that. And then these support groups. So like being with other parents who've been through similar things is really can be like a game changer for some of these folks who just cannot imagine themselves thinking or feeling any differently. It also may be worth exploring and doing more assessment around where this resistance is coming from. What would it mean if you did accept your child? What's getting in the way of you being able to accept your child and affirm? And then, one common thing that comes up often is this is inconsistent with my religious beliefs. There's a lot of merit and benefit from connecting folks with LGBTQ affirming spiritual or religious leaders. They exist. It may be a bit of work to find them, but as an example, in my setting, we have a chaplain who's non-binary. And that's been so helpful for many of our clients who, because of their kind of religious upbringing, have internalized stigma and are very, judging themselves and having a hard time with that. Connecting them with a spiritual person who also shares an identity or lived experience can be really healing and empowering, and still, culturally affirming and responsive. Okay. Quickly moving in. This comes from the reference that I have below. I know that we're talking about queer health, and in the spirit of, not taking these things in isolation. I do just want to bring up anti-racism and the importance of, really thinking about an equity approach to the work that we do. It's important for DBT therapists to be, thinking about their own cultural responsiveness and their commitments to being more equitable, and encourage folks, if you're on DBT teams, to add agreements. So like our team here has an anti-oppression and anti-racist agreement, and that is just below life-threatening behavior. So we kind of couch it within therapy interfering behavior, and we think about it like a system interfering behavior that otherwise is getting in the way of therapy. We prioritize this on our agenda. We read these agreements, and ensure that we're attending to this so that it is not an out of sight, out of mind type of thing. I just mentioned that. All right. So how do we create validating and affirming treatment environments? So again, these may not exist for folks in their environments otherwise. And so we can do that in our own treatment spaces. These kind of levels of validations are the ones that I think would be most useful because we are, in fact, living in a current context that's quite hostile. I just want to do a quick note about functional validation because this is something that comes up very often for people who kind of, again, well-intentioned, claiming to be allies, saying like, yeah, I'm wearing the pin and I'm doing all this kind of stuff, but when it comes to actual action, they're not really engaging in things that are affirming, and this can feel really invalidating to LGBTQ plus people. So here's a scenario that kind of is similar to that. If you see someone walking through a door, they have a bunch of heavy bags, they're clearly struggling, and you're like, wow, that looks really heavy. I can see that you're struggling. I'd be super frustrated too if I were in your shoes. So like it sounds validating, but is it like definitely not? What would be more validating is if you held the door or took some of the bags. So, when treatment facilities kind of, claim or have on their websites, although that's less these days, like, we're affirming of all identities. And then you have, doctors who don't know about your health history because they don't have any training, or there are no representative brochures in the waiting area. That's not functionally validating. And we have to be thinking about what is going to be functionally validating for LGBTQ folks when we're working with them. So how do we create these spaces? It comes from the language that we use, the visual cues within the environment, how we're interacting. Is our staff trained? Being thinking about like who's the person that they're going to be interfacing with first. Is that person using correct name and pronouns? What do our forms look like? How are we using assessments? What happens when somebody makes a mistake? And what kind of resources do we have? I'll go through these quickly for the sake of time, but we want to be paying attention to the kind of language that we use. And again, it's important for us to do our own homework, not just like learning terms, but also like consuming media and following influencers, even if it's not necessarily what we're personally interested in, just so that we know, what the environment is like. Having visual cues, these are not just symbolic gestures, like certainly in isolation, maybe, but they really matter. Having non-discrimination statements prominently displayed, making sure that you know about like when Pride Month is, or Transgender Awareness Month, or Transgender Day of Remembrance, things like that. In our interactions, maybe consider introducing yourself with your name and pronouns, having your pronouns in your email signatures, avoiding unnecessary questions, avoiding relying on clients for knowledge, and ensure that all staff are trained appropriately. Considering the kinds of categories we have within our intake forms, are those inclusive? And then own mistakes. We're all going to make mistakes. It's fine. It's not fine, and it is. But we want to just make sure that when we do, we acknowledge it. I'm going to apologize. I'm not going to make it about, my upsetness that I just did this to you, and I'm going to commit to correct it in the future. And then where are the resources going? Visual cues are necessary and also not sufficient. Do we have resources allocated? Do you invite speakers who, speak on this kind of content area? Do we have materials? All right. No, we're going like ludicrous speed now because we've just got a couple minutes. What I want to end on is that this work is hard. Some of you may have identities yourselves that are under attack right now. That's a lot to carry. And then you have the additional kind of stress of showing up to work, and being someone's support who's struggling maybe with same things. Even if you don't have identities that are under attack right now, this content is just, it's bleak, it's difficult. So it's important to also take care of yourselves and think about ways that you can be sustainable in this work. Things like alternate rebellion, I've definitely found a lot of positive coping and using that skill. Rely on your teams, talk about this stuff. Remember and remind yourselves of your professional ethics, and relevant codes, especially when you might be asked by your institution to do something that is inconsistent with that. Use your wise mind and speak up. Go to where angels fear to tread in the systems where you work, and make sure that you are working to flex your privilege. And then lastly, stay informed to get connected. These are a ton of resources, many of which are tailored to LGBTQ young folks, adolescents, including but not limited to the Trevor Project, which is an amazing organization. It was actually responsible for some of the references that I did earlier. So I want to just thank all of you for your donation today, because it is going to the Trevor Project. And here is another slide with resources. Whew. And I'll stop there with 2 minutes to spare. All right.
Thank you so
Sorry
much
for the quick speed, but I wanted to make sure I gave you a bunch of content.
If anyone has last minute questions, feel free to speak up. So just to reiterate, all proceeds today are going to the Trevor Project. The link to donate is in the chat. Instructions on how to get your CE credits will be sent out shortly. That's it, Colleen. That was awesome. Thank you so much.
Thanks for inviting me.
I did want to say, coincidentally, as we were having this webinar, Andrea Gottlieb sent out an email on the listserv asking about resources of what to do if ICE shows up at their clinic. So if you're on the listserv and you do have resources that you could share, please do respond to her. All right. I hope everyone stays warm and strong, and we will be in touch with future webinars. Thank you so much.
Thanks, everybody. Take care.